It's a good question because I don't know if we're ever going to have anything, at least in the next couple of years, that resembles normalcy, especially in the ER and our ICUs. There will continue to be COVID patients. We'll continue to have to think about them and how they're interspersed with our other patients. What's going to be important for us is how we transition from a couple of weeks ago only seeing COVID patients to now starting to see some chest pain patients and some stroke patients a lot more than we were. We have to think about how we take care of both of those patients, those patient groups, at the exact same time and stay safe. The one thing that's really important, and the message that I want to share, is that if you need to go to the emergency room for COVID or non-COVID reasons, if you're having chest pain, if you think you're having a heart attack, if you're having a stroke, you absolutely need to go. We have so many people that are showing up saying they didn't want to come because they were worried that coronavirus was in the hospitals. It's true, but we need everyone who has these life-threatening emergencies to continue to show up. Otherwise, people are going to be sick and die at home.
So Dr. Spencer, it sounds like there's still a lot of pressures on the key healthcare providers in terms of capacity. Does that mean that we shouldn't be doing any form of reopening yet? Or actually, is it a worthwhile, not gamble to take, but test to take to see where it leads us?
We closed a lot down and we did all the social distancing, and we implemented this over the past couple months, the past month really, so that we were able to buy time to do the things that we needed to do, which was increase the amount of testing that we were doing, look into other treatments and therapies, and really start to build a public health system that could approach this in the right way. We're talking about now increasing testing to have 2% of the population tested per month. That's better, but that's not nearly enough. We need probably at least 500,000 tests done per day if we want to open safely. This shouldn't be a state-by-state thing. This has to be based on the situation that's happening anywhere. New York City is very different than New Mexico right now. We should have different plans. We should have different criteria for how we're approaching that. That being said, we need to be thoughtful about relying on things that work. Bread and butter public health, which is testing, testing, testing. We need way more testing than we're doing right now. We need isolation. We need contact tracers, people to make sure that we can open up to some sense of a new normalcy safely. Because if we just open up, relying on a small amount of testing, crossing our fingers, we're going to be back in the same situation in a few weeks and in a few months and really into the next year.
Dr. Spencer, as you've seen more and more of these COVID-19 patients, is the illness at all becoming predictable? In other words, can you tell when a patient comes into the ER just how sick they'll be based on their symptoms and their labs and what course they'll take?
It's an interesting question because I worked in West Africa during Ebola. And the first couple of days that I was there, I didn't know who was going to have malaria, who would have Ebola, who would have something else. But you get pretty in tune in the span of a couple dozen patients in a couple of days. I think what's hard with COVID is that it can present as everything and anything. Yes, we talk about cough, fever, shortness of breath, but sometimes it's abdominal pain. Sometimes it's a headache. Sometimes it's vomiting. Sometimes it's old people. Sometimes it's young people. I think we're all getting a little bit more in tune with what the majority of our patients look like. But we're finding that when we test people who have non-traditional COVID symptoms, fever, cough, shortness of breath, we're still doing CAT scans and x-rays on people and finding out they actually have COVID as well.